Welcome to this explainer. So if you're gearing up for your USMLE Step 2 or Step 3 exams, you already know that managing infective endocarditis is incredibly high yield. But let's be honest, it can also feel like a total maze of rules, random exceptions, and tricky drug regimens. Well, today, we're going to completely demystify these complex guidelines. By breaking down the source material into a really clear, logical framework, we're going to get your brain totally prepped to tackle any clinical vignette with absolute confidence. Let's get into it.
Here's our quick roadmap for today's explainer. First up, mastering IE prophylaxis rules. Then, avoiding the prophylaxis traps. Third, we'll hit early prosthetic valve treatment. And finally, native valve MSSA therapy.
All right, Section 1, mastering IE prophylaxis rules, narrow indications for antibiotics. Let's dive right into this first crucial concept, which is the highly restricted criteria for preventing endocarditis before it even starts.
So, I want you to actively think about this for a second. Out of all the patients with heart conditions you see walking around the wards, who actually warrants prophylactic antibiotics before a procedure? You might be surprised, because the list is actually way shorter than you'd think.
The guidelines have gotten incredibly specific over the years to promote better antimicrobial stewardship. Basically, prophylaxis is reserved for patients at the absolute highest risk for severe outcomes. It's a highly exclusive club. To get in, you need a qualifying cardiac condition, which means a prior history of infective endocarditis, having prosthetic heart valves or prosthetic material, unrepaired cyanotic congenital heart disease that was repaired with prosthetic material within the past 6 months or left with residual defects, or finally, being a cardiac transplant recipient who developed valvulopathy. That's literally it, and here's the kicker. They only get prophylaxis if they're also undergoing specific high-risk procedures. We're talking dental procedures involving the manipulation of gingival tissue or perforation of the oral mucosa, or invasive respiratory interventions. In these specific scenarios, we're trying to prevent transient bacteremia from bugs like Viridans group Streptococci. And when they do qualify, amoxicillin is going to be your go-to agent.
Moving on to Section 2, avoiding the prophylaxis traps. Don't take the bait. Let's see how this builds into the absolute most common pitfalls you'll see on your exams. Test writers love to tempt you into prescribing antibiotics when you really shouldn't.
Okay, watch out for this classic bear trap. You are absolutely going to see a clinical vignette featuring a patient with mitral valve prolapse. They might even throw in a very noticeable murmur or mitral regurgitation just to stress you out right before the patient heads into surgery. Do not fall for it. MVP is not considered a high-risk cardiac valvular lesion that requires prophylaxis.
In fact, let's just explicitly list out these traps so you can immediately cross them off on test day. Do not give prophylaxis for mitral valve prolapse, aortic stenosis, mitral regurgitation, or a bicuspid aortic valve. You also hold off for small acyanotic ventricular septal defects without prosthetic intervention. And what about routine GI and GU procedures, say a bladder prolapse repair without an active infection? No way. They do not carry a high risk of significant bacteremia. Prescribing prophylactic antibiotics in these contexts does literally nothing to reduce the risk of infective endocarditis. All you're doing is exposing the patient to unnecessary drug side effects and actively contributing to dangerous antimicrobial resistance. For these folks, the best prevention is honestly just regular dental care and good oral hygiene.
All right, Section 3, early prosthetic valve treatment, when things go wrong. So, knowing when to withhold treatment is great for stewardship, but what happens when a patient actually develops a severe infection after getting a valve replacement? We have to shift gears from prophylaxis to aggressive treatment.
First, we need to define early prosthetic valve endocarditis, or PVE. This is an infection that happens specifically within 60 days of valve replacement surgery. This short 60-day window, it is a massive red flag. It dictates a very specific, aggressive empiric therapy approach because patients in this time frame are at an incredibly high risk for multi-drug resistant organisms, particularly coagulase-negative staphylococci, MRSA, Enterococcus, and gram-negative bacilli.
So, when you're selecting empiric therapy for early PVE, you need the heavy hitters. The guideline-supported standard is vancomycin plus gentamicin. You absolutely need vancomycin for essential coverage against MRSA and coagulase-negative staph. And then you add gentamicin to enhance bactericidal activity and achieve synergy. Test writers will try to distract you with inadequate therapies. Ceftriaxone alone, totally insufficient. It lacks MRSA activity and synergy against enterococci. What about linezolid plus ceftriaxone? Sure, linezolid covers MRSA, but remember, it's bacteriostatic, not bactericidal. It's way too slow. Effective treatment of endocarditis with prosthetic material requires rapid bacterial killing. Plus, prolonged linezolid use brings along some nasty toxicities like thrombocytopenia and serotonin syndrome.
Now, I can literally hear you thinking it. Wait, isn't gentamicin famous for nephrotoxicity and ototoxicity? Yes, absolutely. But it's all about weighing the scales. In this highly specific, high-risk context of early PVE, where the mortality rate is just off the charts, the benefit of early aggressive bactericidal synergy with gentamicin completely outweighs the risk of nephrotoxicity. You monitor their renal function super closely for sure, but you do not withhold the drug up front.
And finally, Section 4, Native Valve MSSA Therapy, Targeted De-escalation. Let's look at how we handle native valve infections once the blood culture data actually comes back from the lab. Say you have a patient with a history of IV drug use presenting with a tricuspid valve vegetation.
We are going to walk through a very specific clinical sequence that gets heavily tested because it proves you actually understand antimicrobial stewardship. Step 1. Your empiric cultures return and confirm methicillin-sensitive Staphylococcus aureus, MSSA, and let's say the patient has no beta-lactam allergies. Step 2. You immediately stopped a broad-spectrum empiric vancomycin and gentamicin. Step 3. You start a narrow-spectrum beta-lactam, specifically nafcillin or oxacillin for a standard 6-week monotherapy course, assuming no metastatic complications.
So why do we make this switch? Because targeted nafcillin monotherapy hits the absolute bullseye. It is actually clinically superior to vancomycin for MSSA. Beta-lactams get higher peak serum levels and way better tissue penetration in endovascular infections. This means faster clearance of bacteremia and a shorter hospital stay for your patient. On the flip side, keeping a patient on vancomycin plus gentamicin once MSSA is confirmed is just terrible stewardship. Vancomycin is inferior for MSSA, and keeping gentamicin on board adds zero survival benefit for native valve staphylococcal infections. All it does is massively increase the likelihood of blowing out their kidneys.
Let's rapidly eliminate some incorrect multiple choice options you might see for an MSSA infection. Gentamicin monotherapy? Never. It's bacteriostatic against staphylococci on its own and highly toxic. Ceftriaxone monotherapy. It's kind of like bringing a weak sword to a gunfight. It's great for strep, but has really suboptimal bacterial killing for MSSA compared to our anti-staphylococcal penicillins. And lastly, daptomycin. Daptomycin is a cannon. It's a fantastic bactericidal drug, but using it for MSSA is just way broader than necessary. You really want to reserve daptomycin for MRSA, VRE, or patients with severe beta-lactam intolerance.
I really want to emphasize this core quote straight from the source material. Knowing when to narrow therapy is a crucial skill in managing endocarditis and limiting toxicity. Appropriate de-escalation improves outcomes. This right here is the heart of what the examiners want to see. They want to know you have the guts to escalate aggressively when a patient is in that dangerous 60-day post-op window, but also that you're smart enough to de-escalate to a narrow beta-lactam the very second your culture data allows it. And that brings us to the end of our explainer. So, are you going to confidently spot those mitral valve prolapse traps on your next exam? For sure you are. But honestly, beyond the USMLE, remember this. As antimicrobial resistance continues to grow globally, your prescription pad is either a protective shield for your patient or a weapon against public health. Which one is it going to be on your next shift? Thanks so much for hanging out and learning with me today, and I'll catch you in the next explainer.